Quick disclaimer. Opinions of host and guest do not represent the views or opinions of Functional Movement Systems. Always consult your physician before beginning any exercise program. This general information is not intended to replace your healthcare professional.
Welcome to the Movement Podcast. This show is all about movement. We tackle it from different angles, bring on guests, answer questions, go on a few tangents, and give practical advice, giving you guys a better idea of how you can optimize the human body to be the best it can be. Let's preview what's coming up in this episode.
From hernias to C-sections, a large part of the population will experience an abdominal procedure at some point in their life. But after the incision heals, is there something we're missing when it comes to its effect on movement? Today we discuss core surgeries. We cover ways movement is affected after going under the knife, our own personal experiences with hernias, physical obstacles after a C-section, and strategies to get your movement quality back after surgery. So let's get to the core of the issue on today's episode of the Movement Podcast, powered by FMS. Probably one of the most common things you see on Instagram, social media, even when people probably come in to get training, is they want to do some type of core work, core training, get their abs and all this. And great, to be honest, there's such a huge part of the population out there that's had a core surgery that a lot of trainers, and I would even say medical professionals, don't consider before they start prescribing some type of core work. And I think that is, that's a big problem, because statistically speaking, there is a lot of people out there, probably, 30% of the population that's had some sort, maybe more, some type of core surgery. I mean, you and I both have had our fair share. I mean, I had a hernia, you've had a hernia, and just being able to navigate through that, because unfortunately, once you go in there and whatever surgery you get, whether you're a female or you have a C-section, whether you're guys like us who've, again, 25% of the population have had a hernia surgery, you don't know what to do afterwards. And you're not given a lot of, information as just a person going in. The surgeon does their surgery, fixes the problem, and goes on about your day. And lo and behold, 3 months later, you still feel a little something, but you really don't know what to do. And that's a problem.
Well, I think you hit the nail right on the head. If we saw the word training attached to any part of the body, core definitely wins hands down. Now, we all know that most people who are concerned about training their core just need to change their diet and drop about 30 pounds, and all of a sudden you'll get to see what you're working with. So I think a lot of people want a weight reduction program or a fat reduction program. And it doesn't mean that the core doesn't need to be adequately trained. But one of the things that goes far back in my orthopedic practice, back when you and I were practicing together, you were running the sports medicine show. So almost everybody that you were working with was considered sports medicine orthopedic. You had the red phone. You could call any orthopedic surgeon in town. They'd answer your call. You could pretty much get what you needed to rehab these kids. I noticed two specific types of surgery that in my mind fell under the orthopedic umbrella that never got a PT or chiropractic referral, and that was podiatry and general surgery. Now, a podiatrist is somebody who's whittling on your feet and cutting on your feet, and I, early in my practice, developed a few relationships with the podiatrists and said, let us help you out with the other stuff. That foot's not the only thing wrong. They got a stiff hip, they got balance issues, and we had some really nice outcomes. And then I started talking to some of the general surgeons, and it never even occurred to them, because they were removing a gallbladder, an appendix, repairing a hernia, or because a OB-GYN did a C-section, they didn't see that they were doing orthopedic surgery. But when else would you poke or cut through a major muscle group and not think that it was affecting the orthopedic system? Well, you remove an emergency, appendix, you save somebody's life. So you don't think about the repercussions. But I started on my orthopedic exams in the early days, because you were seeing all the young athletes and I was seeing everybody else. And I would always ask males and females, have you had an abdominal surgery? And if it was a female, I'd say, have you had a C-section or a complicated pregnancy? Because a complicated pregnancy can do just as much trauma to the pelvic floor and internals as cutting through the abdominal wall. And it was a significant pattern in recovery when somebody did have their abdominals interrupted. I would almost always see a significant T-spine rotation asymmetry. A lot of us treat that like a mobility problem and think if we just rack and crack your T-spine and stretch out your intercostals, you'll turn. You're not turning because you don't want to have to stabilize in that awkward position. And if your abs have been interrupted with a surgery or a trauma, but it's simply that. I don't think general surgeons are considering going through that abdominal wall in orthopedic surgery. And by orthopedic standards, it may not be considered that way, but when we look at what happens to the hips, the balance, and the low back after an abdominal surgery, we're picking up risk factors every time.
Right, and the average person out there, and I'll throw us in the average category. You may not think we're average, Gray, but pretty typically average here.
I think you're pretty average.
But when we go in, we're thinking about taking care of the hernia. In our case, but if we talk about, again, the statistics say about a quarter of the people have had hernia surgery. Most common abdominal surgery, general surgery, most common. Then you got appendicitis. Then you have gallbladder. Those are fairly common. So you're, again, talking about a fairly large percent of the population. And you're going in saying, fix the problem, right? And you're not going in thinking, as you said, thinking about what's going to occur afterwards. And then you start getting back to your daily routine. Lo and behold, you forget about it. And then physiologically, there's a lot going on. Whether you have for me, going arthroscopically going through the belly button and having a few little pinholes in there, but underneath the skin, they're having to go and weave through a lot of fascia, and they're breaking through a lot of tissue to put, in my case, the mesh in. And what are you really losing? You're talking about what happens, the person loses some rotation, but it's that proprioceptive input. It's we all know now how much influence fascia has on the system. But you're really talking about a lot of neural input that you're losing, that you're breaking through. It's scarring down. And that's what you really need to go back and try to get back to a degree, right?
And I think you hit the nail right on the head. And an easy way I want our listeners to explain this is, if you had somebody's movement perspective, their balance test, an SFMA, an FMS, and then you saw them have an incident like a hernia and repair, or a pregnancy and a C-section. These are going to be the most traumatic. And then if they're left on their own, because this happened right on our campus down in the war room where we do all our writing. Matt had a hernia. And he got himself a truss, which is a little brace that you walk around with. And he was sort of pretty conservative, going to try to, see if he could, get himself out of it. And I kept saying, no, you got to repair your hernia. And then there's a lot you can do.
All right. I'm going to interrupt you because I think that, I treated myself very much the same way. And I think that's probably, again, the average guy, or, because guys have more hernia surgeries than females. Mm-hmm. The average person out there will try to just, because for me, and I think this is probably typical, it's not a huge problem, meaning it's a problem, but it's not something that's taking you off your feet. It's not something that's really impacting your daily activities. Now, as you said, it's not going to get better. It's going to continue to kind of get a little worse. You can do whatever you need to do. And I knew the day I pulled mine. I knew. And the problem is, when I had my surgery, the surgeon came out, and of course I was waking up, said, "Hey, how'd it go?" He goes, "Well, I went in there to repair both, but that one on one side, it was like cutting through glue. It had just been, because it'd been probably 2 years that I was just trying to deal with it, trying to do basically what I know as a professional, stretching and certain things I could do. I mean, shoot, I think you went in and dry needled me a couple of times, just trying to help me out a little bit, just to try to make me move.
Well, just so the clinicians can hear this, we did some soft tissue basically on your hips. Lee had a femur fracture when he was a kid. It's created a lot of asymmetries. And I said, hey.
You usually make fun of that when you tell that story.
Well, I probably will before the end of the episode. But, he's just running around in the backyard, and apparently he never drank a glass of milk, didn't have enough calcium in the system, popped his femur in half. But that created not so much a leg length discrepancy in you, but you got two different hips.
It created a leg length discrepancy.
It did too?
Yeah. I said at that age, because I was 10, it created a little leg length discrepancy. And, because you're growing. And when I'm growing, that side wasn't growing for probably 2 months like it should have been. It was healing, but it wasn't lengthening like it should. So I think it's right around a 1/2 inch leg length discrepancy, and I've never been diligent in wearing the little heel lift that I should do. So
You also
now you can carry on.
Yeah, you also have a internal external rotation mobility deficit. Anyway, Lee presented with symptoms like a pulled groin / hernia. I could needle out the tighter of his two hips and do a little bit of stuff on his back and abs and get him lined up, but it wouldn't hold. And that's where I think Lee and I both agreed. I definitely think you got a hernia. And by the time it was repaired, he had been dealing with a hernia for a couple of years. And I was born with a hernia. Okay. So I think we could say, do we think the hernia is causing orthopedic problems? Or is it a complication with orthopedic problems? And I think, Lee, your hernia was a complication to a mismatched set of hips that you couldn't do anything about. I was born with a hernia, but have had quite a few issues that could easily be traced back to my core, extremity fractures and things like that. My hernia was repaired at 3 weeks old, again in college, and then I had the trifecta the third time. I had 3 different hernias, 2 old, need to be repaired. So you can come at this either way, as the hernia is the primary driver of an orthopedic issue, and I think I fit that category. You and Matt downstairs both had a pretty good leg fracture during a growth spurt, and sure enough, in your 40s, after years of your athletic ambition and active life, you had created this problem. And I remember I've been saying, Matt, you just got to go get that surgery. And he's a little bit reluctant. And you came down one day, and I guess it was a double team intervention.
He's not going to listen to you. You guys are brothers. It's just like me trying to talk to my teenagers.
So he found one of the better guys in town, got the hernia surgery, was really satisfied with his outcome. And, the guy basically said, yeah, you're going to be good to go. Don't lift over 20 pounds for 6 weeks. And then Matt said, and that's it? That's all? And I'm like, well, you walked around with a hernia for about 8 months. You've developed a completely different movement pattern. Here's what I usually see.
Hold on. I'm going to interrupt you again, because here's what my surgeon told me. So my surgeon told me, same thing, don't lift over 20 pounds. And I did it at a time that I knew I wasn't traveling. I knew I wasn't doing much. And I want to go out, and I'm not a good golfer, go out and play some golf. And he said, oh yeah, 6 weeks, you can go out and play golf, no problem. I'm going, you don't want me to lift 20 pounds. You don't want me to do hardly anything, and all of a sudden I can go out and swing a golf club. As bad as my golf swing is, that's okay. And it is, according to them, because they fixed the problem. Yes. And I think that's what how a surgeon looks at things, not in a bad way. But in essence, Grace, surgeons are like carpenters. They're going to go in with the tools that they have and fix the problem. And then that's it. They're not going to think about the things that really, what a lot of people are listening to us right now saying, okay, well then what do we do?
Right, and quick tangent, that they are obliged to look at the body through a structural lens, and we're obliged to look at the body through a functional lens. And just like the Senate and Congress, we're supposed to battle it out and work it out so the outcome is best for the overall good. When we look at an ACL reconstruction, a ligament in your body's gone, and we're going to replace it with something structurally stronger than the ligament that was there.
Typically 110% stronger than the ligament that was in there is what they're getting ready to put back in you. But what's the problem?
Tolerate this tangent. The natural ACL you have is in direct communication with the muscles that can help it if it becomes under higher than preferred tensile stress, okay? So your ACL, your PCL, your MCL, your LCL is all integrated into a network that has a reflex stabilization trigger, okay? So if your ACL is stretched, long before the signal of, hey, this is inappropriate stretch, makes it to your brain, it loops through a spinal cord reflex and actually creates integrity around the joint through muscular contraction. The ligament that replaces that one is structurally stronger, but it is not plugged into the network. Now, the good news is other ligaments are, the capsule still is, and you can develop pretty good movement patterns. We've seen it in the NFL. However, these are already highly talented, highly kinetic, highly proprioceptive aware people. When you do a ligament where your abs usually attach to your pelvis, that's integrated too. And if you're looking at the decline in somebody's movement patterns while they have the hernia or the pregnancy or whatever, and then we repair that, just like you said, you don't default back to normal software. You default back to the last software you used when you walked, which was a little bit of a limp, a little bit of a wider base, a little bit of a gait deviation, and poor balance.
And that's a natural response to some type of injury in the body. And we'll use the hernia as the example, or even appendicitis. You know, the body's going to try to protect itself. It's going to decrease the amount of motion you have so it doesn't stretch out those structures. And the hernia is a great example because that's what's occurring. So your body's not going to want to allow you to stretch through it. So it's going to, and I don't even want to use the word scar down, which that'll happen, but your brain's not going to let you move in that direction. And over time, that's going to create problems. And if you go 2 years like me and 2 years, you know, length of time like Matt, which I think a lot of people do because they just don't want to deal with it, they develop those poor movement patterns. And then afterwards, the brain goes right back to those poor movement patterns.
Let me do this. There's a thing we see with a lot of knee issues called quad avoidance. You learn to walk around and even go up a step not using your quad. You basically position your foot and pull yourself up there, you know, hamstrings, and push with your glutes. But I don't think anybody's ever coined the term core avoidance syndrome. Let me tell you what a core avoidance syndrome looks like.
Please do.
A 1 on the leg raise and a 1 on the push-up. Okay, and we see that. So we see that in adolescence, and we don't immediately think hernia. We just think if you can't lift your legs any higher than a 1, the one thing that I don't think about is, why is this kid's hamstring so tight? Why is their posterior chain working so much harder than their anterior chain? Because those hamstrings aren't just tight. They're still on even when the quad should be lifting your leg up to a 2 or 3. I've noticed that in myself, and I've noticed it in other people. So the dead giveaway that core is begging for help is the fact that you got 1 or asymmetry on the leg raise, your rotary stability and your push-up is out. And long before you put them on their feet and call it functional training, I think you need to go back through some developmental cycles. And we've been proponents of that all along. Matt and I were just doing an article about that. He's coming through his hernia surgery and said, you know I can't get up off the floor. I know I don't ever want to do a bretzel again the way I feel right now. And the funny thing is, he had gotten so many behaviors, walking around, doing farm work, doing all his things with that hernia, that you learn to avoid engaging your core and creating the intra-abdominal pressure that actually stabilizes your back. So you get a harder posterior chain in the process. You get a little bit of a sway back, you get a little bit of anterior pelvis, you get, you know, tight hips.
And great, I would say, let's make it clear here. That's not always because you have a hernia, or that's not always the result of a hernia.
What happens right before a hernia? Your abs are weak.
Right. Well, but I think that also happens in a lot of individuals out there who are just moving poorly. They are creating these compensations. And the one thing where you and I saw this a lot, and this probably goes back 10, also 15 years ago, back when the sports hernia was all what everybody was talking about, you could spot that from anybody who had a 1-2, 1-3 on the leg raise. And somebody who was at a high level sports place, whether that's NFL, Division I athletics, who couldn't even do a push-up. And they didn't have necessarily a hernia in the traditional sense, but they had some issues in the core where they had surgery. And those surgeries that we were seeing back in, early 2000s, when this was the sports hernia, pubalgia, whatever you want to call it, was a lot more because of that asymmetry and those issues they had in the lumbopelvic region. I would argue maybe even some of the training they were having. And again, going in and creating and doing the surgery didn't still fix the problem.
That's right. And let me go back to one thing. Most every high-end athlete we've ever seen can do a push-up if we let them do it their way. But when we put them in the FMS criteria push-up, what I want all of you to see right now in your mind's eye is we've got you planked out for a reason. If you dump stability before you bend your elbows and go down, you've already lost it. And so the push-up is called a push-up in the functional movement screen, but we all know it's a core integrity test. Will you give up your core to placate your quads and your pecs, or will you hold your core and make them do their job? And when we see somebody who can lower but can't come up or something like that, it's actually a stability test under stress.
Reflex stability test.
Yes, it's reflex stabilization. situation. And if you'll choose your upper body and lower body before your core in a push-up, then you're probably going to make that mistake in single leg stance and cutting and turning and jumping as well. And that goes right back to, the situations we see when people are usually in that category of having low back pain or spondies or something like that. We also see them very, very weak up front. But the movement patterns that we develop when we have that general core weakness or even that core injury are very, very fundamental. And I want to throw out an exercise that I took a certification in Pilates mat work a billion years ago. No machines, nothing, just you on a mat doing some of the original Joseph Pilates stuff. Joseph had a exercise he called the curl up. And it's easier to start as a negative. If you're sitting up in a toe touch position and you decide to lay back down, most people won't lay down one vertebrae at a time. They still have that little bit of lordosis. They really sort of invoke their iliacus psoas, and they sort of lower themselves down like a 2x4. And what Pilates said is, no, make L5 kiss the floor, make L4 kiss the floor, all the way down till you get to about mid-thoracic spine, then lay your head down. When you come back up the same way. If you would look at people who have completely recovered from their C-section, hernia surgery, abdominal surgery, whatever, they're not doing a curl up.
All right. So when you say completely recover, because I think we were talking about hernias because that's personal for us, right?
Yep.
But C-sections are very similar because you take a
more traumatic
well, right. But yeah, more traumatic. I mean, you and I certainly can't appreciate that. But a person who's had that C-section where they really had their abdominals cut open.
Yes.
And they healed up, but what's a common side effect of that is a year later, 6 months later, they're trying to go back and start training, but they can't control the bladder. Right. And that's a common result.
Or low back pain.
Or they get low back pain, and I would argue that most of people don't want to have that conversation, especially if you have a male trainer that you're working with. But I think that's a common occurrence too. We just don't like talking about it, and we don't know. A lot of people don't know what to do. So I'm going to ask you this, and I'm going to let you go off on this one, because I think the common thing people are probably listening to us talk, and whoever's listening to us talk right now are like, well, what do we do? Well, you just gave one example of what to do, and I think that holds true, but you just said they couldn't do it. So one thing that if you follow us, well, you know that we're always going back to this neurodevelopmental sequence and always getting back on the floor, build you back up. And I would say this is probably one of the best scenarios where that holds true. Get you off your feet, get you back on the floor, and you started talking about Matt, and I think it holds true even with females having a C-section. Get back down there, because there is things we can do.
And I think we brush against it. When somebody is out of their prime, they're not going back to the gym to lift heavy weights. They're seeking out things like Pilates, yoga, maybe some martial arts on the side, just a little bit of body control stuff instead of just me controlling weight. And so I think that when some of these people who've had an abdominal issue go back through yoga the right way or Pilates the right way, they're going to be down on the ground a lot, just like FMS and SFMA would say, fix them on the ground. If your rolling's broken, I'm going to find problems with everything above that if we look hard enough. And a lot of times you and I will find people with single leg stance problems. And we'll take them all the way to the ground, reinstall rolling, stand back up, and single leg stance passes. Whereas a whole lot of people would leave them on one leg and try to train them to balance better instead of grow that.
Stick them on a BOSU and say balance.
Well, hell, we used to do it. And I think we were just a little bit self-aware because we had a screen in our back pocket that said, yeah, that was a great 15 minutes. You didn't change crap. Any asshole can make somebody tired. But it takes a little bit of skill to fix movement.
What's even more fundamental than rolling? And that's breathing. How many of these people probably also have a little breathing dysfunction that need to be addressed?
And back in the old days when I was still one of the guys teaching the SFMA and we would break somebody down and take them to rolling, the one thing that I would always try to point out is on the side where we already knew they were going to have difficulty, they would preempt it with a breath hold. They would try to stabilize their intra-abdominal pressure because they couldn't breathe and roll at the same time. And any movement that you can't do and breathe at the same time is not going to be a movement you do well. It just is not going to be. And so noticing the little ways that people would try to brace up just to roll from their back to their front or front to their back. And I've been that guy, right? After the hernia surgeries, after the neck surgery, I've been that guy, so I know how it feels. But we can't just look at these moves as sets and reps anymore. When we're using rolling and quadruped and planking and side planking and bear crawling and balance beams, if we're doing this to fix something that's not a fitness problem, it's actually a healthcare problem, then the same medicine that can cure you can kill you. And the only difference is the dosage. And so when you're going to start using movement patterns to get somebody out of a hole, as opposed to just keep them fit, I'm going to get a little bit tighter on me as a professional, looking you as a professional, saying the minute you're dropping this as a medicine, meaning it's got to fix something, you better damn well know what you're shooting at, and you better damn well prove to me it made a difference for the investment we did. And I say that to myself every day too, so I'm not trying to be an asshole out there, but the minute you move into exercise as medicine, not exercise as fitness, entertainment, or general physical education, you better be closing cases instead of assigning sets and reps.
You want to improve your kettlebell workouts? Indian clubs may just be the missing link. While kettlebells are great at improving strength and power, Indian clubs are great at improving your speed, coordination, balance, and flexibility. Pairing these two can drive positive results across your entire workout. Club swinging is a perfect complement to kettlebell training. When you have compensation and struggle weight training, you often pick up bad form. It's almost impossible to get bad form with Indian clubs because those things either move or they're awkward. In the course, we cover classical moves all the way to advanced moves and even show you how they can be used as correctives in your workout. If you want a greater challenge, check out our clubs course at functionalmovement.com.
Get 30% off the FMS Introduction to Indian Clubs online course using promo code CLUBCOURSE. That's promo code CLUBCOURSE for 30% off. Offer valid for a limited time only.
And let's talk about that rolling just for a second, because you're talking about rolling and planking and quadruped diagonals. A lot of these, what we look at is these very fundamental kind of going back to that sequence of growth and development where, let's go back to the most fundamental, breathing. Make sure you get your breathing right. When we go into rolling, you're talking about segmental rolling. You're not talking about log rolling, because you said something right there is like when you see these individuals who've had some of these issues, and the first thing they do, even you said yourself, they almost tense up. They breath hold, they try to increase the intra-abdominal pressure, do that Valsalva, and then it's more of a log roll. And that's what you don't want to see and with what you're really looking at.
It's the dissociation. We'd like, if we tell you to roll from the bottom up, say you're laying flat on your back looking like a snow angel you're getting ready to do. If we tell you to roll from the bottom up, we'd love your shoulders to stay flat on the ground and see your pelvis make the turn. If we tell you to roll from the top down, we'd like to see your pelvis lay flat and you really make the turn in your shoulders. What we see and what you're describing is when people have to lock up their core, they end up throwing the extremity as sort of a weight to pull them across instead of doing it with integrity. And what you usually see is people who roll wrong, they fatigue very quickly when they roll, whereas people who roll right, because we don't all roll once a day, get out of bed, they actually start doing it better. They get better as they go because they're waking up a dormant movement pattern, but it was never broken. And so there is so much more in rolling, but the minute you try to turn it into an exercise, you're almost practicing the test. So we like to do rolling and then do a lower body motor control screen or an upper body motor control screen, thus using a baseline that's not the exercise to confirm the fact that we woke up a dormant pattern. We didn't teach you a new way to compensate. And I think that's very important when you're doing the neurodevelopmental sequence to juice the system with some of these moves. But if you practice them and rehearse them so much, you'll almost lose the integrity that they give us. And that's why I'm very adamant about not practicing the neurodevelopmental progression, because it should be in there. And as we know, you're going to run into mobility problems first. But it doesn't mean stability problems aren't behind that. Mobility, locking up your spine, whether you do it with muscle tone or whether it's been stuck so long your spine is just stiff and it doesn't bend, neither option is good, because now your spine that was made to move a lot when you're in developmental positions, but when you're running or doing a kettlebell swing, your spine is supposed to be a transfer lever. But a lot of people use that as an excuse to say, my spine's supposed to be stiff. No, your spine's supposed to be stable. Stiffness you can't control. It's stiff all the time, and that's not a good thing. Stability is situationally appropriate, and I think that's a much better word. So when you're rolling on the ground or bear crawling, your spine's supposed to move, because it's not vertically loaded. But when you're vertical, your spine is a transfer lever of kinetic energy between your legs, or your arm and your leg, reciprocal patterning and stuff like that.
And Gray, what you're describing is really important, because I think most people, and this gets confusing, is there's no question. Is it a mobility problem? Is it a stability problem? And most people coming out of these or going into these type of core surgeries have what would present as a mobility problem.
Absolutely.
Because that's what the person is doing to protect the injured area. They are not moving a certain way, not rotating, for me, not moving my hips the way they need to, because my brain knows there's a problem in my intra-abdominal area, that if I move too much, it's going to increase the tearing that I have in those structures. So your body's going to, in essence, protect itself. But underneath, once you break through that mobility problem, it is a motor control or stability problem that is the underlying thing. But in order to address that, Gray, and I think this is where the confusion comes in, you've got to break through that mobility issue. And you may use, here's where the confusion, you may use a stability problem to do that, or stability technique to do that.
You could, and just as a sidebar here, we've got a sample of our listeners that just responded to 40% of the listeners that responded to this little survey we just did said they had a core-based surgery, one of the 3 or 4 or 5 that we've been talking about. Now, we know that our listeners are probably a little bit more active than the general listening audience in America, and I think active people are going to stir up a hernia or an abdominal problem a little bit quicker than somebody who just sort of slowly does a little bit less each year. But for our listeners, even before you go try this with a client or a patient or athlete, I want you to look at a Pilates curl up and attempt it. It's always easier to do the negative first, but one of the main reasons you're not going to be able to do that has nothing to do with strength. It's got to do with spinal mobility. So if you've got some safe ways to get your spinal mobility back, the Bretzels are safe, some foam rolling is safe, just using a partner to stretch is safe. But as soon as you can get a Pilates curl up where you can do it correctly, both concentric and eccentrically, the next transition that I would say, me being a therapist and talking about this problem in general, is those tall kneeling turns that we posted a long time ago, because under that little bit of load, whether you carry a bag or a plate weight or a kettlebell in front or behind you, in that tall kneeling position, your quads don't like being that stretched out. And your spine doesn't like being that straight up, and yet biomechanically, you're exactly where you're supposed to be.
Yeah, and let's back up, because when you talk about that curl up, because I remember the curl up being a big part of what we would do back in the clinical days, and it is a underutilized exercise, because most people look at that almost as a crunch, and everybody knows what the crunch, the perception of the crunch is so awful. But someone coming out of core surgery, they're not going to be able to do it.
They're not.
Sit down, lower yourself. So how can you make it easier?
Well, we've often used.
And let's make sure they know it's not the crunch that traditionally.
No. Your legs are flat. Your knees aren't bent. And I used to do this with a lot of my even older patients. I would get them to make a wedge at home, and I was like, if you got nothing more, an ironing board will work. Lean it up against the couch. But if you go ahead and elevate your torso 45 degrees with your legs flat on the floor, almost every person on the planet can start their curl up there. And if you peel away 10 degrees after every 3 sessions, they'll get pretty close to the floor. Some people will never get a full curl up, but if you've given them enough so they can go through their forward bending and backward extension patterns, top tier of the SFMA, with more mobility, don't think for a minute you haven't increased more stability.
So
as
basically build the ground up so they're not
Exactly.
going down. So whether that's as you said, ironing board, pillows, whatever it is that's going to build that ground up so they're not going to go all the way to the floor and then slowly move that away.
Yep, and as most people know, squats are way easier with a heel lift, and curl-ups and sit-ups are way easier with a torso lift, and whatever lift-off they need. How many times have you worked with a kid that couldn't do push-ups, but they got steps at home? And if you'll start on the third step and do your push-ups this week, visit the second step next week, first step week after that, you're going to be on the floor doing push-ups before the end of the month. And
So Gray's recipe for some of these issues coming out of these type of surgeries, hernias, even C-section, get your breathing right.
get your breathing right.
Do some type of rolling. Ensure you got your basic, get your mobility back. Do some type of rolling and not traditional log rolling, segmental rolling. We got a lot of this on our website. Go to our website under Exercise Library, type in rolling, you'll see a lot. And these curl-ups. I mean, to be honest, that's 3 or 4 pretty solid things that could get somebody and then get them up to the tall kneeling, and you're building them back up.
And the one other one that I had, and I realized from yoga, the happy baby, just grabbing your own feet. And the mobility to do that may take some people a little while, but putting your feet up on the wall and inching your butt closer to the wall will help you get that. But what we started doing with the happy baby about 3 or 4 years ago is just gently trying to roll left and right. And if you get stuck, then put some couch cushions on each side of you and just wobble yourself in a happy baby. And it might be 2 or 3 weeks before you can even attempt a partial curl up. But believe me, that happy baby mobility in yoga is not for babies. It's for adults who need to get a little more mobile, like babies.
Yep, bringing your feet up to your face, and that's what babies did a lot. Just to open up those hips, basically it's getting your hips and your lumbopelvic kind of synced up.
Exactly.
Before you do something.
Right. And if any of these movements are painful, please put on your clinical hat and say, okay, reset them so it's not painful, and then give them the move so they can reinforce it without you having to reset them so
All right,
much.
put on your clinical hat here, Greg, because I think here's the other problem. And, you know, my wife's had two babies, and she's gone through this, and I know that's something that needs and can be addressed. And I'm not talking about her now, but these females who have the C-section, who do some minor stuff, but still have that problem in that lack of bladder control, incontinence. There are clinical things that can be done to help those individuals out. I think, to me, it still goes back to being able to have that conversation. If you're a trainer, have that conversation to make sure that you can get them to the right person. Because clinically, a lot of people don't know this. I know a lot of listeners out there probably do, but a lot of people don't know this, especially the people you're training, don't realize there are clinical things that can happen that can be done as a physical therapist to help you with that problem.
I got to enjoy the early front end of this because one of our colleagues at the first clinic we worked at was early in the pelvic floor part of rehabilitation. That's a big part of physical therapy right now in women's issues. And when I would have a female who fit that criteria, had probably had an abdominal surgery or chronic low back pain, had a little bit of incontinence on questioning, they're here seeing Gray Cook for low back pain. But I would often say, listen, I'd like you to see one of our female therapists just for a few of these other issues. Within 3 or 4 sessions, not only would some of the pelvic floor concerns be addressed, 50% of the back pain that I was getting ready to be Gray Cook on was already gone. And the rest of the back pain was exactly in my wheelhouse. So when you're thinking of that pelvic floor issue, it's way more prevalent than you think in males and females, and it goes hand in hand with a thing called a high threshold strategy. Now, a high threshold strategy is actually using your obliques and rectus abdominis to plank even when planking isn't necessary. And we see this in a lot of athletes that have trained too hard, a lot of people who've lifted weight incorrectly, and then people who have a surgically challenged core that are just trying to get through life. We actually invoke more oblique than we need. Our TA goes to sleep, but with all this holding our abs in all the time, what gets compromised? Our diaphragm range of motion and our pelvic floor both get pressurized. So we can go months without taking the deep breath we need, and we can go months putting undue pressure on the pelvic floor, because now we're a cylinder that doesn't move in and out. We put pressure up and down, and you don't want to compromise your breathing or your pelvic floor. These are two things that need to do what they do. They're two trampolines.
And what you just described, I think, is too often what gets prescribed.
Yep.
It's that high threshold, planking, the quadruped diagonals, the, holding the Valsalva. You go right into lifting, thinking that's going to be the problem, but they're just covering up these underlying issues, which are pelvic floor issues and breathing issues, which are compounded because a lot of those high thresholds lead to mobility problems.
Well, that's what we see, because people who have really got good looking and what we would consider strong abs by gym standards seem to quickly lose rotary stability. Okay, so if I trained your quads so well, Lee, that you couldn't squat anymore, I might have gone off the rails a little bit. Your quads are supposed to be strong, but never limit your ability to squat. If your abs are so strong, they limit your ability to use your pelvic floor and diaphragm the way you need, or rotate your T-spine so you can really get the advantage of reciprocal motion, running, jumping, and stuff like that, then we've gone too far. And that's sort of a superficial kinesiology 101, everybody's got weak abs. No, I don't even think people know where their abs are. And it starts, believe it or not, with your TA. And your TA basically keeps you tall and upright. It doesn't crunch you or do anything. And so when we start over-prescribing abdominal strengthening, when people don't even have stability, if somebody doesn't have good single leg stance, they could still have really strong abs, but really poor stability, meaning they try to preempt their abdominal response because they've been vulnerable for so long. And so I really do think that if you've trained somebody and they do have strong abs by holding standards, but they've lost movement patterns, that's no different than training your quads and losing your squat.
I think where, back, early on in the movement screen days, but even I'd say things we teach now, get into that half kneeling pattern. You're talking about single leg stance, but you get somebody in a half kneeling, you go up to them and tap them, and they can't hold that half kneeling, especially on one side. There's an underlying issue, and doing planks is not necessarily going to fix that. Planks are great at every exercise. A lot of exercises are great, but planks in general are great at the appropriate time. Side planks, full planks, but it's that one layer below that often gets overlooked, and that's really what we're talking about.
It is, and two other things that became apparent when I was reviewing some of the stats we got here on this. By the way, 2% of all babies are born with a hernia, most of those being males. I guess I fall in that 2%, but it's something to look for. And hernia,
so that means you're an elite person?
I am. I'm an outlier. But I do think with the birth weight of American babies, the fact that we're big and strong and stuff like that, we're going to start seeing more of these before we see less of these. So the hernia is going to be something I think we need to be hyper vigilant about. And those of you listening, I really think you could make a strong case to talk to a few of your general surgeons if you're in the line of rehab and just say, listen, let us just screen them. We don't have to do rehab on everybody that got an abdominal surgery, but wouldn't it be good to go back and look at the risk factors of movement patterns, asymmetries, and balance issues? Because this could either cause or complicate these things, but let's not assume that not lifting over 20 pounds for 6 weeks is gonna fix this when there were probably a lot of problems that led up to this.
Well, and the other thing, a lot of people, let's be honest, most people don't exercise, they don't eat right, they do all the things, all the risk factors that we know are out there. But a lot of these people coming out of these surgeries want to do better. And let's take advantage of that. And having that conversation with the general surgeon to say, listen, let's try to prevent these from a reoccurrence. You've had some reoccurrence, not that you're not exercising, but let's take a proactive approach. Let's not just give them, don't lift 20 pounds, a gallon of milk for 6 weeks and then go out and play golf. There's a big gap right there. Don't lift 20 pounds, but yet, okay, after the 6 weeks, you can go and do whatever you want. Give them the opportunity to create a little bit of education so they know here are the steps to get you back to what we all as professionals really want, become more healthy. So maybe we do allow them to exercise a little better, give them these things of pieces of information so they can be a little bit more healthy than what they were when they're going into the surgery.
Exactly. Two moves that are very old and very popular. First one is the oldest, is sun salutation. It's pretty much done, standing up and then bending forward, doing each hip individually, but basically you end up doing a negative push-up and then a press up for extension. Getting your breathing right when you do that usually takes most people who don't know yoga 2 or 3 weeks. And I would seriously challenge all of our listeners to go back to something as simple as you think a sun salutation is and do it correctly. It doesn't need to be done with a weighted vest on or anything like that. Find a good video and follow that. But then if you look at the inverse of a sun salutation, you've got a Turkish get-up. One is getting up from your back and the other is getting up from your belly. And if you simply embrace both those for what they are, okay, I honestly think a movement screen, an SFMA, and a Y balance test aren't going to be a big deal. And that's why the people that came before us probably didn't need nearly as much movement screening or integrity as we need today. But I found that a lot of fitness professionals, when they simply challenge their mobility and stability patterns on a sun salutation with absolutely nothing but their body weight and a Turkish get-up with very low weight in your hand, just enough so you can get up under it, find everything they need to work on for the next quarter of their training cycle. And the movement screen would point that out with crosshairs, but these two moves, one downward facing and one upward facing, cover 360 degrees of humanity, and one's probably over 4,000 years old and one's probably at least 400 years old. And it's right there in front of you. Give each one of them 3 or 4 weeks to sculpt you, and you'll run into some barriers. Breathe through them, stretch through them, work through them, and you're gonna be 4 points better on a functional scale just by confronting these. Because
it's gonna take both of those moves takes into account a lot of the recipe that you mentioned earlier. It's just kind of putting it all together in those two moves. And so if a person, Gray, I would say if a person has problems in those two moves, which we know a lot of people, I mean, let's think about it.
As long as it's not pain, I suggest you work through it.
One of the first things I've seen with some of these individuals who are really deconditioned, haven't worked out, you ask them to do a Turkish get-up, well, the first thing they have difficulty doing is getting on the floor. And then they can't roll, which is part of the Turkish get-up. They can't even roll to the side. Well, what happened? There's your rolling pattern. Start with a rolling. Sun salutation. Start with the basics. Break it down a little bit more up until you can get to that point. But your recipe is really it culminates to those two moves.
It does, because I've looked at the sun salutation and the Turkish get-up almost through the lens of the FMS, saying if these movements are nearly effortless to you, doing them correctly, I'm not going to find a problem when I screen and do a balance test on you. And I want to requote Kelly Starrett. We did set the bar low in the FMS. I mean, if you have higher ambitions in athletics or your physical life or even your recreational endeavors, and you're stacking up a bunch of ones, that's a problem. And, John Tureen predicted this way before we had the data. He said, listen, when I got guys with 3 asymmetries on the FMS, that's when I start getting scared of a sports hernia, because they're strong enough to move everywhere except their core. Their core is going to take the beating that running around, cutting, stopping, jumping, turning, twisting, getting tackled with these asymmetries is going to evoke on the central core of your body. So John called it. And right now, one of the risk factors is having multiple asymmetries on the FMS or multiple ones on the FMS. And so John's like, when I've got one of my extremely explosive, fast guys that's got a bunch of ones and 3 asymmetries, he goes, it's not
it's when.
Yeah, it's when they're going to break down. And if they don't have that classic sports hernia that I don't really think is a hernia, they're going to tear a hamstring or they're going to have low back pain.
Well, and I think one thing you mentioned there is we set the bar low, and I think that almost intimidates a lot of people, because they're worried that, I'm going to tell them they've got all these dysfunctions and they're all screwed up. It doesn't matter. The bar is the bar. I mean, all we're doing is setting a baseline. I don't care where that baseline is. If you're working on a person, you just need to know where it is, and they need to know where it is, because you and they need to know, are they getting better? Mm-hmm. It doesn't matter that whatever they score on the FMS, it doesn't matter.
The baseline's more
baseline.
important. The baseline's more important. And when you have a client, an athlete, or a patient that you have time to do a movement screen on and they score low, there's 3 scenarios I would like you to consider. Number 1, is their rehabilitation of their last problem incomplete? And are they forced to compensate because somebody on watch didn't do their job, and it could be them, right? Not following the advice that somebody gave them. The other 2 scenarios are you're doing too much or not enough. And too much winds up being usually over-specialization. We see a lot of runners that all they do is run and they lose movement patterns quickly. We see a lot of athletes that are very asymmetrical. Tennis, golf, they're doing
Well, those football players you were just describing from my buddy John Tureen.
Exactly. So they're doing too much of one thing and therefore not getting a full nutrient diet of movement, or they're not doing enough. You're basically avoiding all the things that are difficult for you, and that's not a good way to go into old age either.
But bringing it back to the core surgeries, you mentioned the first thing you're looking at did they not complete their rehab? That's this core surgery. The rehab wasn't even prescribed, but they're coming in to get trained by you as a professional. That just tells you where you need to start. Do you need to go back and start with breathing, with rolling, with, half kneeling activities versus can you start with some of the higher levels traditional training activities? It just gives you that starting point. And knowing that they've had a core surgery gives you that little bit more insight that says, you know what? This is how they scored. This is how they're moving. This is how they're functioning. But the fact they had a core surgery 6 months ago tells me most likely we need to do something different.
No, I agree. And let me flip it almost 100% now. How many therapists and athletic trainers know how to recognize hernia behavior if somebody's not pointing at their groin, right? Because they will have a hip impingement, they will have low back pain, they will have poor single leg stance on one side, they won't like doing leg raises, they won't like doing toe touches, and they definitely won't like deep squatting. So there's a lot of other things that can keep you out of good movement patterns, but I find that most therapists are more comfortable rehabbing you from a hernia than they are recognizing it in the first place. And so I think there's a great coming together here if physical therapists get on the front end of recognizing the hernias. They're coming. They're coming through your office every day, and you're treating piriformis syndrome, low back pain, psoas issues, all these things. And so we need to know how to refer out and get that hernia. Usually a GP can help you identify that. Not just rehab people who've had the surgery, but recognizing that many musculoskeletal problems could actually start in response to compensating for a core weakness that you can't strengthen them out of. And so,
those same people are going to be showing up at the gym.
They
thinking
are.
that,
and they're never going to say, I got a hernia.
I'm a little tight, I can't do this. And you're going to start training them. And lo and behold, 3 months into your training, it gets worse because it's not going to get better.
Right.
I mean, once you tear that abdominal wall, it needs to get. There's a lot of other things that are going to come after that will lead to bigger problems. So I think you hit the nail on the head, Greg. Great point. You got to recognize how these things present, and don't shy away from a referral to a GP. And again, have that conversation with the person, and maybe have the conversation with the general practitioner, this general surgeon.
Yeah, just know this, that when we look at the way trigger points refer, the trigger points in the abdominal complex and in the hip flexors mostly refer to the groin or low back. So, when I hear single-sided groin complaints or single-sided low back complaints, that's when I start thinking. When I see asymmetrical leg raises, when I see people who can't even begin to do a sit-up even though they can squat their body weight plus, then I start thinking, what could be affecting the abdominal wall? I want to be wrong every time. The last thing I want to do is be 2 weeks into rehab with somebody and then recognize the fact that, on top of this low back pain diagnosis and this balance disorder they got a hernia, and neither of these two things are going to get better if we don't address that first. So I want PT and chiropractic to do your diligence and not try to diagnose a hernia if you've got no training, but definitely get in that thought mode, because you can get some collaboration on that. And secondly, how better to set yourself up to help them after the repair if you're the one that was cognizant enough in the beginning to help identify the problem, not as, hey, let's just throw more heat and stem on your back and see if you feel better next week, you know? So I think we need to be serious on the front end of this. Athletic trainers, we need to have these conversations. And like I said, you don't have to go, but everybody on your roster, if you run a bunch of movement screens and you see otherwise high-end athletes with ones on the leg raise and bad push-ups, it's okay to start asking those questions, because it's two sides of the same penny.
So, great. We talked about breathing, and we say get your breathing right. It's one of the most fundamental things that we have to do. So how do we recognize that as a problem?
Well, I think we just ask a few simple questions. Number one, do you have frequent congestion, frequent sinus infections, seasonal allergies? Is there a lot of time where it's not comfortable to breathe through both nostrils? Okay, just ask that question. Do you snore? Do you basically, have you had facial trauma? Do you have a deviated septum, a broken nose, or something like that? And another history of breathing problems, bronchitis, asthma, something like that. People will volunteer this information very, very quickly. And if you watch somebody just take a closed mouth nasal breath, you can hear a lot of resistance or not. And the other one is, do you find that you're a mouth breather when you exercise? And if you simply ask these questions, it's easy to go right from there into something as simple as a breathing screen. And tell us how simple that is.
Yeah, I mean, come on, Gray, you're not selling our breathing screen here enough, buddy. I mean, we have for you professionals out there, I would highly recommend. This is obviously a shameless plug, but that's what we do. Highly recommend looking at the breathing course that we have. And, there's a lot of information that's out there. And Dr. Rosalba Courtney, who helped Dr. Kyle Kiesel develop both assessing breathing, and then Kyle developed the breathing screen. A lot of information. Now that I think, it seems to me, Gray, breathing has become a lot more mainstream. People are talking a lot of.
Oh, on the other side of COVID, we got PTs doing way more O2 saturation on your finger than we ever did before. They're looking at COVID, but a lot of these people were poor breathers before COVID hit, and those are the first ones that COVID got. They already had vulnerability and risk factors associated with breathing, and now you get a breathing pandemic coming at you. Who do you think it's going to attack first? But breathing.
Again, most people who probably who are having COVID problems have these comorbidities, and I would say these people who are having COVID problems are also had breathing problems going into it.
Yes. Most people who aren't breathing well enough to, say, respond favorably to exercise, for the first time, we got to do what martial arts and yoga never split apart. We don't teach movement without teaching the favorable breaths of each. And one of my recipes, and I've had this, and Kyle confirmed it with a lot of the stuff he found on breathing, is if you're doing a flexion movement, I'm bending over to touch my toes, I'm going to exhale. And if I'm doing an extension movement, I'm going to inhale. If I'm going to squat, I'm going to exhale. Now, that's different than if we were lifting weights.
Yeah, make that clear, because we're going to get all the.
We got to take everything back to the squat rack. So
yeah.
No. If you already have a breathing issue, then the first thing we do is get your breathing in a favorable alignment with your movement.
And that's what you mean when you say get your breathing right. It's connecting your breathing appropriately with your movement patterns. You said the breathing screen. The breathing screen will just tell us if we have a problem. That's the purpose of a screen. And in addition to those questions you mentioned, there's a couple other questions that Dr. Kiesel found in the research, but you should be able to hold your breath a minimum of about 25 seconds.
And to qualify what Lee's saying, if you had somebody sit in a chair, not leaning in the back of the chair, and they were already at a resting breathing rate, and then all of a sudden on your command, if they would just grab their nose and hold their breath, what we don't want to see is how long you can go before you pass out. We all know we can make it way past 25 seconds. What we'd like to know is, do you have the comfortable urge to breathe? Because at that first comfortable urge to say, I think I don't want to do this, go ahead and breathe. And if you fall under 25 seconds and you don't have a major breathing history, we can probably sync you back up with your movement pattern. And so one of the cool things about looking at movement and breathing together is we can go backward in movement to rolling on the ground, to planking, to doing quadruped moves. And you're breathing fine. And all of a sudden you come up to half kneeling, that key position, that transitional position. And I've seen this happen with very accomplished triathletes and runners. I'll get them with their unfavorable hip down, okay? They immediately take on an inefficient breathing pattern and they smoke out very, very quick. So whether we're playing med ball catch or whether I'm doing some perturbation or isometric holds with them, this is somebody who could be in an Ironman and they just smoked out in half kneeling. I have no illusion that I hit their cardiovascular limit. They are so inefficient in this pattern that they can't hold themselves up and breathe a full cycle at the same time. They're high thresholding, they're planking their way through it, and it becomes obvious when they go almost sympathetic here. So there's certain positions where people look unbelievably weak and unstable, but please recognize that they're probably not breathing authentically there too. The pattern below that, the posture below that, we got to make sure they're breathing good. Let's get them breathing there. But when we find that they're going into extension with poor stability or inflection with poor mobility, let's start syncing their exhale with flexion movements and their inhale with extension movements. And that's the small amount of intra-abdominal pressure that helps you extend because you lost that proprioceptive trigger. And so we've done this in the toe touch progression, but so many people are focused on the move, they forget the fact that I'm up there coaching breathing the whole time. And I think breathing's 2/3 of it. I really do. It's not just toe lift, heel lift, bend over and touch your toes. It's exactly what I'm saying in their ear. And I let them do a few moves before I coach their breathing. I let them get through it, and then I show them how much syncing their breathing actually makes it easier for them.
Yeah, and not everybody needs to have this so much emphasis focused on breathing. That's the point of a screen. And the way the screen, there's some questions in the screen, takes probably all of one minute to do this breathing screen. But it puts you, again, it sets the baseline. Because, okay, yeah, I'm going to listen to everything Grace said. I'm going to do these exercises. All right, do you know if it's getting better or not? The only way if you know it's getting better is to set that baseline. Now we threw out 25 seconds. There's some categories. There's a lot more. There's a lot more to the breathing screen that can give you some specifics to make sure. What we should need to do is make sure you're reliable and you get the right information to set the baseline. So then when you do everything you described, you know if you're getting better.
And let's say you've had the courses, you understand what we're doing, and you have the capability to do, say, a balance screen, a movement screen, and a breathing screen. Well, if the breathing screen is really the one that concerns you most, it's lower than the other two are, then I can actually use some of your easiest movements to calibrate your breathing and sync it with movement. Because if you don't sync breathing with movement, you're only gonna breathe well when you're in a chair or in bed. So you gotta sync breathing with movement. It's the natural trigger. However, if your breathing's good and your movement's bad, I know I don't have to go full Wim Hof and have you hyperventilate, but I can actually have you overbreathe to create the signal of integrity or relaxation. Most of us who think we have mobility problems are coming at our mobility work with high tension muscles, meaning we've been planking our way through the day, trapping ourselves through the day because we got poor core stability. So when I'm looking at something as simple as your motor control screen, your movement screen, and your breathing screen, one of those is going to be blinking at me more than the other. If they're all low, I'm still going breathing first because I can use what you learn in breathing to make your movement patterns better. But really, you don't have to fix them all. There's going to be a movement component and there's going to be a breathing component, and I'm using one as the advantage and one is basically the therapy, and I can flip it based on where you score the lowest. So that's what is refreshing about having this little breathing baseline, this movement baseline, and this balance baseline. And the whole thing is lay all three of them out and play one and use the other two and watch what happens. That's the baseline is for you, not just your client.
That'll do it for this episode of the Movement Podcast. Thanks for listening. And if you liked what you heard, please take a minute to subscribe and review. If you want to learn more about our system and take the next step in your movement journey, visit us at movementpod.com. Until next time, be sure to first move well, then move often.